month. June is always a busy month for everyone. So without further ado, we'll have Dr. Braswell take over the screen, and we will look forward to hearing from you.
Thanks, Dr. Pat, for the introduction. If I haven't met anyone yet, I'm Matt Braswell, one of the third-year orthopedic residents. I'll be talking today about talus fractures. I have no financial disclosures. It's just kind of a game plan for what we're going to go through today. We'll start off with a couple of cases. Case number one, this is a 37-year-old male who fell from a height, was seen at an outside ER and actually sent, just told to follow up in an orthopedic clinic, was sent home, had severe pain, as you might guess, and overnight develops new plantar numbness. And as you can see on these AP and lateral x-rays, has a talus fracture with a subtalar dislocation, and unfortunately sat like that overnight. Second case is a 30-year-old male, high-speed MVC, came in with a hindfoot deformity and swelling. As you can see on these x-rays, this talar neck fracture with tibiotalar and subtalar dislocations, which was found to be irreducible in the emergency room. So these are just a couple of cases. Get us warmed up, and we'll come back, circle back to those later. So starting off with some anatomy, there's a really nice description of the bony anatomy of the talus as a domed box with a stout cylinder projecting anteriorly, and I would just add slightly medially as well. It's augmented with posterior and lateral processes. Another unique thing about the bony anatomy of the talus is that there's actually no muscular or tendinous attachments, although there's a recess for the deep deltoid and a sulcus for the FHL. The real story of the talar anatomy is the articular surfaces. So that it's greater than 50%, depending who you read, somewhere 50 to 70% articular cartilage. Inferiorly, there's 3 facets that articulate with the calcaneus and the subtalar joint, as well as we know, the tibiotalar and talonavicular joints. This unique articular anatomy leaves very little surface area for perfusion, for blood supply. It also affects the fact that if there's fractures in the talus, it's very common for them to affect the joints or involve the joints and be displaced across the articular surface. This anatomy also limits our options for approaches and exposure for fixation. So understanding this kind of unique facts about the talar anatomy is crucial to understanding our fractures. The vascular supply of the talus, so the dominant supply is from the posterior tib circulation through the artery of the tarsal canal. That's followed by the second most dominant, the tarsal sinus artery, which is from the anterior tib circulation. And then there is perineal perforators, which provide antegrade perfusion to the talus. And the 2 dominant posterior and anterior tibial circulations form an anastomotic sling inferiorly. So how do we classify these? Anatomic classification was first described, as you might guess, just based on the anatomic location, and they divided talar neck and talar body fractures at the level of the lateral process, with fractures posterior to that being body fractures. The Hawkins classification is one that we hear about a lot, and this is specifically for talar neck fractures. It subdivides those in a helpful way as it's diagnostic and prognostic. And the OTA and AO classification essentially combines the anatomic classification with the Hawkins classification. So Hawkins, again, subdividing these talar neck fractures. Type 1 is non-displaced. Type 2 is involvement of subtalar joint. Type 3 adds the tibiotalar joint, and then type 4 is a pantalar dislocation. And the Valier et al. Paper subdivided the type 2s into 2A and 2B based on whether the subtalar joint was subluxated or completely dislocated, because they found a significant difference, almost 20% difference in the rates of post-traumatic arthritis based on whether the joint was fully dislocated or not. The epidemiology of these fractures, more recent studies have shown that it's actually closer to 2% of all fractures. And we're finding more of these as people survive more motor vehicle collisions, and talar body fractures are more common than talar neck fractures. When these patients come in, of course, we have to start with our ABCs, airway, breathing, and circulation, our ATLS protocols. Physical exam is crucial, a great motor and sensory exam to the foot and ankle, as well as a vascular perfusion exam, and then a good examination of the skin. both to evaluate for any open fracture component and to evaluate for pressure spots on the skin from extrusion or subluxation of the talus. Very high rates of associated extremity fractures, but a good place to start is usually with 3 views of the foot and ankle. Looking more specifically at these talus fractures, there's a special view called a canal view, which is a true AP of the talar neck, which is maximal plantar flexion, 15 degrees of pronation, and then moving the C-arm if it's intraoperative or the flat plate about 75 degrees off from the horizontal. This is something that's used mostly intraoperatively to evaluate reduction. CT scan can also be very helpful for these, as up to 25% of fractures, non-displaced fractures, can be missed with plain films. And CTs are also helpful for evaluating comminution and involvement of the joint surfaces. Goals for treatment of this: it starts off with the soft tissues. We want to avoid soft tissue compromise, get these subluxation and dislocations reduced as soon as possible to protect the skin and the soft tissue structures. Once they're reduced, if the soft tissues are in bad shape, we are able to delay operative fixation. That's considered acceptable treatment, as soft tissues can drive outcomes. We want to restore our hindfoot mechanics and avoid varus, and then we want to get stable fixation to allow for revascularization if possible and to allow for early range of motion. Moving on to treatment for these, so non-operative is fairly rare. There has to be essentially no displacement whatsoever, or an isolated dislocation, which is subsequently reduced. As little as 2 millimeters of step off in the talar neck changes the contact pressures in the subtalar joint, and any varus in the talar neck decreases subtalar range of motion significantly. When you have this malalignment, either from non-operative or after operative treatment, it's been shown that this malalignment, specifically varus, leads to pain and dysfunction in later reoperation. Specifically for neck fractures, the approaches really facilitate the reduction. These are usually dual anterior approaches. The intralateral traditional approach can be substituted with the sinus tarsi approach, and these can be augmented with osteotomies for greater visualization if needed. And with these dual approaches, you're able to visualize both sides of the fractured neck and prevent rotational and angular malreductions. Usually, often the medial side is comminuted, as this is a compression failure side, and the lateral side is more simple with tension failure, and often the lateral side can be used to evaluate your length with interdigitation of the fracture. Fixation's truly dealer's choice. There's multiple papers that show neither is really superior, but usually a combination of mini fragment, small fragment plates, and independent screws. Want to avoid over compressing that medial comminuted side, as that'll leave us in varus. Moving on to body fractures, our treatment goals are essentially the same, and often the approaches are very similar with the dual anterior approaches. The one added difficulty for talar body fractures is visualization of the talar dome, especially the posterior talar dome. There's anatomic studies that show that to truly visualize the posterior 50% of the dome, often it's necessary to make some form of malleolar osteotomy or to utilize a medial malleolus fracture that was sustained at the time of injury. And anytime we're putting in internal fixation, we want to think about the fact that there's a real chance that we'll be back and be mindful of where we place our hardware. Talar head fractures are more rare. Only about 5 or 10% of talus fractures. We do often treat these operatively, as the talar head's crucial for maintaining the medial column and the arch. Again, usually with dual incisions, and these often can be treated with either a medial column spanning plate or independent countersunk medial to lateral screws. Moving on to process fractures. So lateral process or snowboarder's fracture is associated with about 20% of all talus fractures. Traditionally, this was treated non-operatively or was excised, but in some recent series, it's been more commonly seen to be treated with open reduction internal fixation, as it contributes to the subtalar joint, and often this is associated with a ligamentous ankle injury, and a ligamentous reconstruction will be performed as well. Posterior process fractures are slightly less common, associated with 18% of all talus fractures. It's important to differentiate from an os trigonum. If there's a large piece that contributes to the tibiotalar and subtalar joints, can be treated operatively with a posterior medial approach. Often this can be seen best on CT scan. As we're intraoperatively and preferably preoperatively, there's three kind of key questions. How will you position? What approach or approaches will you utilize? And then how will you obtain and maintain the reduction? And this should really be our focus as we move to treat these operatively, and the implants can be picked last. Another operative pearl is for reduction of a dislocated talar body, like the case that we heard. Often this requires paralysis with true general anesthesia. Flexion of the knee helps release the gastrocnemius. Traction on the hind foot can help restore length. And then often the body will be palpable for when it's fully dislocated, and you can place direct pressure to help with the reduction. There is evidence to support when the talus has been completely extruded and is picked up on the street, you can clean it and put it back in. There's evidence out of Harborview for that. Specifically for reducing these fractures, talked about this a little bit, but often the lateral side fracture interdigitation can be utilized to help judge length. And really going back and forth between your medial and lateral exposure can help avoid malreduction. There's also indirect signs that you can use. Obviously, you want the facets to be congruent. You can look at the axes between the talus and the first ray, as well as the body and neck angles on both the AP and lateral views. When it comes to fixation, again, the evidence seems to support dealer's choice for this. Structural and cancellous autograft can be helpful when there's combination of the neck, as can some of these mini fragment plates to help with axial and angular instability. So moving on to some complications of this, osteoarthritis is the most common. I remember I had a chief who's going into foot and ankle tell me that it makes sense that all these people with AVN get arthritis, but not all the people with arthritis get AVN. So that's how I remember that arthritis is the most common. It's also the most common reason for reoperation, and subtalar is more common than tibiotalar. If we see rapid joint destruction, especially after open injuries, we always have to think of infection. AVN, although it's less common, is probably more talked about and is a feared complication due to the tenuous blood supply that I talked about earlier, especially with open and comminuted fractures. This can be asymptomatic and can revascularize over time. The risk increases with Hawkins classification, increasing joint disruption. And as you can see in this x-ray here, the classic Hawkins sign is the subchondral lucency, which is a good sign. It's a sign of reperfusion there and avoiding AVN. Once you've exhausted your non-operative management, there are a lot of operative options, both joint sparing and sacrificing and salvage options for AVN and arthritis. I'm not going to go fully into these today, but there's a lot of innovation happening in this area. For functional outcomes, generally these correspond to how much peritalar joint involvement is involved. So Sanders had a series of 70 talar neck fractures, and 26 of this were reoperated on, mostly for arthrodesis procedures, and only 20 healed without any reoperation or malalignment and normal function. So these can be difficult injuries, especially the talar neck. Isolated head and process fractures usually do better. There's a series of 20 snowboarders fractures at 3.5 years. And the operative patients actually were in the high 90s in AOFAS scores, with the non-operative lagging slightly behind, but still doing fairly well in the 80s. And then Anderson et al. Had a series of 8 talar head fractures, and their PROMIS scores were within 1 standard deviation of the population mean at about 1.5 years. So going back to these cases, our first patient, I'll remind you, is a 37-year-old fall from height who was sent out with a dislocated subtalar joint and developed tibial nerve paresthesias overnight. After clinic that day, he was taken urgently for open reduction of his talus. He did well for about 6 months, 7 months postoperatively, and radiographically healed his fracture, but unfortunately developed symptomatic subtalar arthrosis and was eventually taken around 1 year out for selective removal of hardware and subtalar fusion. 3 months post-op was doing well with improvement in his ankle and heel pain. Case number 2, this is our 30-year-old high-speed MBC with tibiotalar and subtalar dislocations, which was irreducible in the emergency room, required take a trip to the operating room for an open reduction, a true open reduction, as it couldn't be reduced even with X-Fix assistance. And this was treated, as you can see here, with some of the techniques we talked about with this medial independent lag screws and lateral mini fragment plate. At the single post-operative visit for this patient, was doing very well. Wounds had healed and had radiographic union, as you can see here. So in summary, these fractures and dislocations about the talus are a difficult problem, but if we understand the anatomy, we can understand some of these challenges and where they come from. Often for primary fixation, you're looking at dual approaches, and there are a lot of innovations for reconstruction and salvage procedures to help long-term outcomes. Unfortunately, you can continue to have devastating complications, especially with high energy trauma and multiple joint disruption. I'd like to thank Dr. Sean, Dr. Karenacher, Dr. Shu, and Dr. Ellington for all their help with this talk this morning. And I'd be happy to take any questions at this time.
Thanks, Matt, for the comprehensive review. Open the floor to questions or discussion.
Hey, Matt, that was a great talk. Do you have a sense for, if we, and maybe some of the other attendees can chime in for clinical pearls, but if we are taking these back in the middle of the night to, reduce because they're irreducible, is it the right call to be fixing them at the same time?
That's a great question, Dave. And I would leave it open to the attendings. I didn't find any good evidence for early versus late in terms of timing of fixation, but I'd be welcome to hear kind of what other attendings' experience has been.
Yeah, that was some of the work that was done too. These used to be urgent, emergent cases. We used to do them in the middle of the night because we thought it would lead to osteonecrosis if you had to fix the neck. That's been asked and answered. The timing is less important. Jamie Bellamy even wrote a paper on really late, greater than 7 days due to the medevac military population. I think that if you have the right crew and you have the skill set to do it, then I think that it does make sense if you want to do it. I don't think that talus fractures take that long, so I think it's reasonable to do. More importantly than that, whether you want to do it or not, if you feel like you need to open it to reduce it, please make an incision that you would use to fix it. Some of these, like they're dislocated posteromedial or something like that, often the body can go posteromedial. I've managed a few of these where the incision is made where the dislocated body is. And so they have this posteromedial incision, which you really can't use to do your definitive reduction and fixation. And so what I'd implore people to do is make real incisions that you could use and extend to actually do the surgery. It's better to do a relatively large anteromedial or medial approach than to do a separate posteromedial incision to reduce it. Does that help, Dave?
Yeah, thank you. And Dr. Shu, in your practice, have you moved towards any primary arthrodesis for any of these injuries?
Also a great question. For me, as you know, I do a lot of primary arthrodesis for calcaneus fractures. Radiographically, up to 100% of these have subtalar arthrosis. The times where I would do a primary subtalar fusion, believe it or not, are actually the lateral process fractures. Because if you actually look at the lateral process fractures, they can involve a significant portion, a third to a half of the subtalar joint, and they're often difficult to reconstruct in a reliable way. And so I'll at least have it on the consent to do that, but I don't commonly do it just yet for talus fractures. And one of the main reasons why I don't do a primary subtalar fusion for the talus fractures is that it's really hard to predict which ones are going to go on to osteonecrosis and actually have a bad result for the ankle joint. And so I don't want to blow out the subtalar joint and then the ankle joint becomes a problem later on in really the subacute phase.
Hey, Joe, thanks for those comments, but your computer seems to be creating some feedback on the call when you're not on mute. So we'll have to figure out why that is.
Hey, this is Ken Ellington. Excellent presentation, Matt. And I got a patient on the OR table. I got to go in, but I just want to echo Joe Shu's comments. Completely agree. And these are difficult injuries with significant morbidity. years down the road. So to be respected on the front end, definitely. So thanks a lot, guys.